Recently, because of a patient who was having intense photophobia, I had to do a phaco with only retroillumination, and that I called as moonlight phaco. But since then I have developed a taste for this technique, and this is another video where I am performing the same surgery. So this is the patient who was supposed to be operated for cataract surgery, and as we can see, it's not a very dense cataract, and this technique is suitable for these patients who have good retroillumination glow present. And here we can see the incision has been made, and we can see a vitreous opacity also. Putting in intracameral lignocaine, and we can see that this is just the retroillumination only. So alongside the rest of the illumination is not very bright, and the glow is excellent. And in this glow we can very well visualize the capsule and the capsular access is being performed, and at the same time patient is not bothered by the intense light of the oblique illumination. So once we have done side port formation and also hydrodissection, then we can ramp up the illumination, because this would be the stage where the lens matter has been hydrated, and now the illumination reaching to the retina is much less because the lens has become relatively more opaque. So in patients who have relatively clear lens and in whom the glow is good, they actually deserve this technique because they have more light reaching to their retina because the lens is relatively clear, and at the same time the steps which can be done using retroillumination can be done at the same point till the lens gets more opaque when the hydrodissection is done. So here we have disassembled and emulsified the nucleus, removing the epinucleus, and as we can see, this is being done under both oblique and retroillumination. So once this stage has been reached, the patient gets very well adapted to the light, and more so this light is less focused because the lens has been removed. So this adds to the convenience of the patient during surgery. Otherwise, as we can see, the microscope illumination is quite bright, and because the light source is quite close to the eye, so amount of energy reaching to the eye is also significant. So this can be a choice in patients with minimal cataract who are being operated, and we can use only the retroillumination for the steps up till hydrodissection, as after that, what I am repeating again is the lens becomes relatively opaque, so the patient is also less bothered by the amount of light if you increase the oblique illumination. And here goes the intraocular lens, and this is a bifocal hydrophilic lens. You can see the rings, and once the IOL is being implanted, the light is more focused on the retina, but at the same time, by this time the patient has get adapted to the amount of illumination. Removing the viscoelastic, and at the same time tapping the IOL so as to push out the viscoelastic gel trapped behind the IOL, and then hydrating the wound and sealing the anterior chamber. It's important that the anterior chamber should be well sealed, and this can be judged by tapping the cornea and looking at the rebound of the tissue. This is the day 1 post-op picture, and we can see the surgical outcome is satisfactory. Thank you.